This was a child who had come to me at 7 years of age with rapid weight gain. So again, the same history. There was infantile hypotonia. The child was growing not well, and he was already 42 kg. So the BMI was pretty much high at that point of time. He had that typical features. There was hyperphagia, developmental delay, behavioral abnormality. So this is something which is also very common, that behavioral abnormality will be important. Now, basic workup was normal, and child actually had classical features of Prader Willi syndrome. And I'm not showing the face here, but they had all the classical features. So this was diagnosed at 7 years of age with these problems. So what would you like to do at this point of time, Vibha, if you diagnose somebody at 7 years?
So at the 7 year of age, we should assess for the pivotal status of the child for the management purpose.
Yes.
Regarding obesity, weight control, dietary,
and the height is also less. So if you look at FDA recommendation, we talk about obesity with growth failure. The general consensus is that any child with Prader Willi will improve on growth hormone, even if they don't have growth failure, because they will ultimately have growth failure. So we at this point of time advised him that he should go ahead and fish study. At that time, it was like 15 years ago, we got a fish, it was positive for Prader Willi syndrome, was advised growth hormone. But the problem was this child did not take growth hormone. Now he came 10 years later on with a weight of around 125 kgs and had developed frank type 2 diabetes. So this was a scenario where we could have prevented this complication from happening if we had given right treatment, right assessment and management at that time. That's why early diagnosis is an important phenomenon. The other basic issue is the challenge of diagnosis. Now, what we often see is that the tests we routinely do, FISH, methylation, even other PCR, often the results are negative. So that is a very confusing scenario. So this we'll be discussing specifically. Naveen will focus about that in that detail. So this is an interesting thing. So Prader Willi syndrome overall is common, 1 in 15 to 20,000 live births. It may be missed because many milder cases may not be missed, like we missed Turner syndrome also. In that perspective, an early intervention is essential in that setting. It's basically a methylation defect, and we'll discuss in detail about what imprinting, methylation, all those things are in that regards. All of you can have a look at our website, learning.growsociety.in, which has got a lot of innovative tools for training in pediatric endocrinology, along with courses, fellowships, and diploma courses. We run 3 modules in the form of grand rounds as well as postgraduate lecture series every month, which you can access through, along with our publications and the mobile application which is there. So today we are going to talk about a specific topic, and we'll use only one case. Normally we have a spectrum of case, but this case actually in itself had all the findings. So this was a very good case which we managed recently with the pediatric unit in the intensive care. So this is basically a imprinting disorder. So when we talk about imprinting disorder, it means that this is a disorder in which there is a variation in phenotype depending upon whether you get the inheritance from the mother or the father. Simply put, in body, there are 2 types of genes. One genes in which both parents' alleles are working, biallelic expression. Some genes, it is only monoallelic. So either the father's is working or some the mothers are working. So imprinting disorder simply means that this is those particular genes which are there in which only one parent's genes are active. So this is an example of imprinting disorder. And what are the other common causes of imprinting disorders other than Prader Willi? Yes, and growth failure. Angelman is opposite to this Prader Willi. Then growth failure. Which one? Russell-Silver syndrome, with Beckwith-Wiedemann being the opposite of that. Then paraganglioma syndromes. So a lot of other syndromes are also associated with precocious puberty. And in fact, a lot of these genes are clustered. So they will be together, close to that in that regard. So a lot of these conditions are imprinted in that setting. So Prader Willi is basically an imprinting defect. The problem in Prader Willi is that this region, 15q11.2q2, which basically means the long arm of 15 chromosome, this particular region, only the father's genes are active. So if your father's genes are not there, you will develop features of Prader Willi syndrome. While in this region, some other ones which are mother's genes are active, if that becomes defective, you will have the opposite picture, which is known as Angelman syndrome. So essentially, the scenario here is that in this region, 15q11, you have got a specific types of genes which encode for small nucleolar RNA. Now we know that there are multiple types of RNAs. Now snRNAs are ones which are more of regulatory functions. They are not translated, so they are not like messenger RNA, but they guide the whole process of translation in that regard. So they are important in that setting, and they also help in post-translational modification. We discussed in collagen, in TSH, in LH, that post-translation glycosylation and other factors are also important determining a biological activity of a protein. So they are very important from that perspective. Now, this is not a single gene. So, of course, this is not a monogenic defect. So this is a whole region which is affected. Depending upon how many genes are affected, the phenotype will be variable in that regard. So there are multiple genes which are there, especially MKRN3 is very, very significant, which is for the pubertal onset. There is also one which is dealing with pigmentation, and there are other features there, and McGill2 also is associated. So Prader-Willi syndrome is a, theoretically we can say it's an imprinting disorder in which a group of genes are affected, and that's the clinical scenario. So defect is, as I said, 1 in 20,000. Most of them have deletion of the father's gene. Some there is a duplication of mother's gene, which is uniparental disomy, or rarely methylation studies. Now, this condition, which we'll discuss more in detail, is associated with increased appetite because of ghrelin and reduced activity of BDNF in that scenario. Manifestation we've discussed: hypotonia, growth failure, hyperphagia, and increased pain threshold in that scenario. So let's go one by one. If you have a paternal deletion, what will happen? You've got only one copy of the gene which is coming from the mother, and these genes are sleeping. So how do we get imprinting? Imprinting basically means that you have switched off those genes. So they are sleeping in that scenario. So the defect is in the paternal allele, most common form. Now, how will the manifestations be? Naveen, what do you think about these cases?
So the most severe of all the types of genetic.
So this is, of course, the worst of all scenario. They will be the most severe disease, and fish will give you a diagnosis because this is deletion. So 60-70% cases fish, and you will discuss more in detail that how fish will help, but this is a scenario you will get the diagnosis immediately. The recurrence risk will be very, very low. Now, if you have duplication of the mother's gene, which is uniparental disomy, what it simply means, it is a complicated term. It basically means that both alleles are coming from a same parent. Uniparental disomy. So the one was deletion, so you had only one copy which was sleeping. Here you have two copies, both are sleeping. So here the problem would be that both the genes are coming from the mother. So this is another important thing, and now it is being recognized more in clinical practice because we have got better genetic tools which are there. Now, what about the manifestations of UPD? Would they be more? But which symptoms are more common?
The behavioral side.
So often we tend to see that they have got a greater amount of issues with regards to attention deficit and autism-like features which are there. And these features are important to evaluate and assess in that perspective. The next is the imprinting center. Now, imprinting center, basically what it means is that there is a center which is located proximal to this particular gene which regulates imprinting. So if your imprinting center is defective, what will happen is that your father's gene may be falsely imprinted. So it is not going to be expressed. So here the problem will be in the imprinting center. What do you mean by epimutation? Vibha.
Silencing is basically methylation of the.
So it is another epigenetic. So you do not have any change in the coding, or the sequence is the same, but the sequence is not working. So this is a very, very cryptic scenario. What happens is that your coding genes are already there, but they are silenced. Once they are silent, then the methylation will also be affected. So this form will be the most difficult to diagnose, and this will Naveen will talk about. Sequencing will be normal in this scenario. Manifestations are the recurrence risk will be less because this is, of course, a specific problem and that particular child. Similar clinical features to the other one. If you have imprinting center deletion, now this could be the next scenario. The center is not there. Now, what will happen in this scenario? Again, you will have an abnormality which you can pick up on a sequencing that is there. But why is this one relevant to identify?
Because there will be chance of the recurrence.
And recurrences could be very, very high. You may have up to 50% recurrence risk also. So that's what question we were asking. Depending upon the genetic defect, your risk of recurrence will be more in that scenario. Now, if you have a paternal translocation, what do you mean by translocation, Naveen?
So there is one chromosome, there is an exchange of genetic material between two chromosomes.
So this chromosome from the 15q11 goes to somewhere else. So that is going to cause a confusion, because then the whole imprinting thing will become absurd in that sense. So you have got this, the entire genetic material is the same, one goes to the other side. So it's a right thing at the wrong place. This is what you can talk about translocation. So here you have a balanced translocation, again rare. Manifestations, they have a recurrence which is high, and it will vary upon depending upon how much your inheritance is. Clinical features, there is no difference. So broadly speaking, if we talk about genetic basis, the most common is paternal deletion. This is what is the classic. So when we say classic Turner, we were saying X0. Same, you have got this classic phenotype, which is the most severe one which is there. But what we need to understand is that there may be milder phenotypes of Prader Willi. So you don't need to always have all these facial features that we discussed, because these will be the most severe cases. So in those scenarios, you can look at other ways to identify. That will be the maternal UPD. Imprinting epimutation, again, milder forms, methylation study will give you a clue. Deletion, PCR will give you identification. And finally, balanced translocation, difficult to identify, but high risk of recurrence in that scenario. Now, in terms of pathophysiology, this one I alluded when we were discussing what happens to the hypothalamic axis. So we all know that obesity, growth hormone levels are low, but IGF-1 are high. But in Prader Willi syndrome, the problem is in the pituitary or in the hypothalamus. It is mainly in the hypothalamus. So it's a hypothalamic defect. So your GHRH will be low, GH will be low, and IGF-1 will be low. So this is important. So if you're doing growth hormone stimulation test in that setting, it is very likely that it will be abnormal. But you will exaggerate the diagnosis of GHD because your GH will be further low because of obesity. So you will exaggerate the diagnosis. TRH will be affected, TSH will be low, but again, this hypothyroidism is central, but your TSH may be slightly more. So what I'm trying to say is that if you have a central hypothyroidism because of a normal scenario and central hypothyroidism due to Prader Willi syndrome, TSH will be higher in Prader Willi syndrome. That's it. It doesn't mean that TSH will be very high, but it may be slightly higher as compared to the other scenario. What about CRF? CRF is also on the lower side. And because obesity causes hypercortisolism, you may actually have a confusing scenario. But very importantly, when you're starting thyroid in this scenario, you're starting growth hormone in this scenario, do a cortisol level, maybe do a GnRH, ACTH testing before you start treatment in those situations. What about GnRH? GnRH is also affected, and we all know that there is hypogonadism. LH is low, testosterone is low. But what about FSH? Naveen? Because there is both central as well as peripheral problem. So interestingly, you may get a scenario where FSH may be high. So this is what you need to understand. In boys, typically they will have severe delayed puberty, micropenis, undescended testis. Puberty may not have any onset, but pubarchy may happen. They will always be infertile. Fertility is not there in males with Prader Willi. Females, they will have severe, because of obesity also you will have a problem. They will have amenorrhea. They may not have periods for 30 years. Pregnancy may rarely happen, but obesity per se will cause a problem. Now, my question to Vibha is, what will obesity do to LH and FSH level? Why?
So
you will have more estrogen because of the fat. Estrogen will suppress, so you will have low. So in morbid obesity in males, you have got hypo, which happens. So again, this is going to worsen in that scenario. So growth hormone axis, we all know that growth hormone levels will be on the lower side. IGF-1 levels will also be low. It's a hypothalamic defect, and therefore there will also be confounding effect in terms of growth. So giving growth hormone in this scenario will be effective. You do not need to do a growth hormone stimulation test in this setting. Now, why are they obese? So the problem is largely at the level of ghrelin. As I discussed, there is also an issue in terms of satiety. So there are two things. One is more appetite and second is low satiety. So other mediators are pancreatic polypeptide as well as a role of BDNF pathway, which is there, but mainly ghrelin is there. HPT axis, I said GnRH is low, LH is low, testo is low, but FSH may be high. So you have this both central and peripheral picture, which happens. There is a disconnect between pubarchy and gonadarchy, and you can often have undescended testis and infertility.
After the diagnosis, genetic diagnosis of the Prader Willi, we'll start the evaluation right from the newborn. First, we look for the tone. As we all know, the hypotonia is the common finding in the newborn period. We look for the weak cry. Then in the growth, we should look for the SGA part, because if the child is born with the small for gestation, it will give us a slight clue about the growth hormone deficiency. We should measure the weight, length, and head circumference. Look for the feeding issues. As they have poor sucking, they have a high risk of aspiration and recurrent chest infections. And we should do the genital examination for measure the penile length, look for the cryptorchidism, and for the genital hyperplasia, which is common in both girls and boys. Now coming to the investigation, there is no need, as sir has already been discussed, there is no need of any provocative test for the growth hormone in the Prader Willi. So look for the just IGF-1 level. And this screening for central hypothyroidism is essential right from the newborn period, as it could be missed in the newborn screening. And this evaluation of the vitamin D is essential, because in many of the patients, the vitamin D deficiency has been found. So from the newborn period, screen for the deficiency annually, do the echo if murmur is present, and do the USG hip for the developmental dysplasia of hip. Now, when the child enters the infancy period, evaluate the growth. In the Prader Willi specific charts, there are specific charts for the growth for the children, those who are on growth hormone therapy and those who are not on growth hormone therapy. Look for the development, as motor development and language and other developmental delay is common. Assess the feeding, look for the calorie intake, look for the technique of feeding, as they will present with failure to thrive. Assess the vision, because they have numerous vision abnormality like myopia, hypermetropia, and strabismus. And again, look for the pubertal status like undescended testis, inguinal hernia. In the investigation, do the thyroid profile 6 monthly in the first year of the life, and then after the first year, do it annually. As it has already been mentioned, like this central adrenal insufficiency has been found in Prader Willi. So do the screening for central adrenal insufficiency. Scoliosis is common finding in the Prader Willi syndrome due to muscle hypotonia and obesity. So start screening for scoliosis when the child is able to sit without support. Do the vitamin B12 level and the swallow study, as due to the muscle hypotonia, they have difficulty in swallowing. These are the Prader Willi specific charts without growth hormone therapy. And these are those who are on growth hormone treatment. Now, the growth hormone treatment, we should begin it with 3 to 6 months, that is before the onset of the obesity, so to get the better results. So what should we do before starting the treatment? What should we do in the evaluation part? So after the genetic confirmation of the Prader Willi syndrome, we should get the basal IGF-1 level, get the thyroid profile, screen for the hypothyroidism, then get the nutrition calorie intake, because we should restrict the calorie intake. We have to reduce the body weight look for the body composition by the DEXA, look for the fat percentage composition, screen for this central adrenal insufficiency, do the scoliosis, do the X-ray for scoliosis. Polysomnography and ENT assessment is mandatory because if the child has a before starting the growth hormone therapy, because if the child has a sleep disorder, breathing, enlarged tonsils, because they will worsen if we have started the growth hormone therapy and without assessment. Get in this glucose or glucose tolerance test and HbA1c. Those who have family history of diabetes, who are obese and whose age is greater than 2 years, and there should be control of food environment. Parents should be advised to lock their fridges and keep the food out of the reach of these children. Now, what should be evaluated during the treatment? Oral glucose tolerance test, thyroid profile, pubertal status, bone age, all should be assessed 3 to 6 monthly. And scoliosis, height, weight, and BMI should be assessed 3 to 6 monthly. And ENT and polysomnography should again be assessed within the first 6 months of starting the therapy. There is no need to assess, do the DEXA annually to the patient, those who are on growth hormone. Now, evaluation of the patients to those who are at the age of 1 to 5 years, assess the feeding pattern, because while entering this age, the feeding pattern changes. They develop hyperphagia, they have a tendency of binge eating, restrict the calories to 60% of what they eat to reduce the weight. Hearing assessment is necessary, do it annually. They have a tendency of developing dental caries due to enamel hypoplasia. Assess for the behavioral changes like temper tantrums, skin picking, food seeking behavior. They have a tendency to eat food even from the garbage. Now, in the investigations, do this X-ray for the bone age, serum electrolytes 6 monthly, lipid profile 6 monthly. Dental cleaning is essential 4 to 6 monthly every year, and scoliosis annually. Now, when the child enters into 5 to 13 years, evaluate for the puberty, as premature adrenarche is common in 30%. It is common in both male and female. Look for the behavioral changes like obsessive compulsive disorder, anxiety, depression, catatonia, and self-harm. So this will lead to this skin picking. So do the skin examination for scars, scabs, and excoriation. As already been discussed, look for the pain threshold. They have an increased threshold for pain. As during the episode of binge eating, this intestinal necrosis could happen, and this will mask the pain. So it is very important to assess the threshold of pain. And in the investigation for pubertal status, do the LH, FSH, estradiol, and testosterone. Fasting blood sugar, A1C every 6 monthly. DEXA scan start from the 5 years of age every 3 to 4 yearly, and multiple sleep latency test is required in those child who have excessive daytime sleepiness to rule out the narcolepsy. Now, what evaluation should be done between the 13 to 21 years of age? In the evaluation, due to obesity, high fat, they are more prone to have the cardiovascular complications. So look for the heart failure, peripheral edema. Look for the pubertal status, as they have a delayed puberty, stalled puberty. Even the males are more prone to have the infertility is more common in male as compared to female. Females will have menarche by the age of 20 to 30 years of age. In the investigation part, get an USG pelvis for the uterine size and endometrial thickness in the females, and get an inhibin B in the females for the fertility evaluation. So here's the summary. What should be done in the evaluation? Growth monitoring, development, vision and hearing, gonadal evaluation, pubertal development, monitor nutrition, behavior evaluation, sleep, scoliosis, and monitoring. Height, weight, BMI, and bone age every 6 monthly. thyroid profile 6 monthly in the first year, then annually. IGF-1 level from infancy 3 to 6 monthly. Serum cortisol annually from the first year. Scoliosis screening from the first year annually. Fasting blood sugar and the lipid profile 6 monthly from the 5 year. Vitamin D level and the vitamin B12 annually. DEXA from the 5 years every 3 to 4 yearly, and polysomnography in the ENT assessment whenever required, irrespective of the growth hormone therapy.
At a website along with our other rundowns and books and applications.